So, good morning all. Now we are going to discuss on the dyslipidemia management, diabetic patients with established and high risk for CV events. So, as we go, we all know all our diabetic patients so as we know, like diabetes per se is a CV risk factor. So the first primary question that I would like to ask Tirthankar sir is, so when should statins be, if at all, avoided in diabetics? We all know like all our diabetic patients need a statin. So when does he not need a statin? So that is the first question.
Thank you, Dr. Gauri, and I thank organizers for inviting me here. I think it is very interesting in the sense that we are always talking of use of statin. So we have come up with a situation when, well, pregnancy that we have been discussing in the morning is something that we shall not be using. But I think there we should also keep an eye on the liver function. Then if you look at the young people with type 1, then you know the ADA guidelines tell at puberty you should screen them for LDL, and if they are less than 100, then you can do it 5 yearly. Then there are other guidelines too. And of course, there are guidelines about less than 35, type 1 and LDL in target. But to be specific on what he said, I would say definitely pregnancy, very, very young people, liver derangements you should consider. And by anything that I would like Arun to add anything if he wants, but...
Thank you. Yes, I think I would very much agree with what he has said. But also, I think what we need to look at is, one, he was talking about the liver disease scenario. One of the common scenarios we see is people who have got a little bit of fatty liver in diabetes, and then suddenly the statin is stopped. A slight rise in ALT, AST that we see in many of our patients is not a contraindication for statin. So I think even if it's double, if it is less than triple, if it's double, it is always best to continue the statin or start the statin and then review the liver function test. In fact, many times it might improve or remain the same. So it may not be related to it. But certainly, I think I take the point that when it's liver disease, you have to be careful. Now, your question really is, when should we be avoiding in people with diabetes? I think there are very few situations where we should be avoiding. And we are talking about Indians. We are not talking about the West. I mean, if you look at the guidelines now, if you're taking I think it's just the ACE guidelines, which is the American College of Endocrinology, they are the only ones who go a little bit slow on statins. Clearly, they are focusing towards the American population, where the cardiovascular risk is much lower. If you're talking about Indians, I think having diabetes itself puts you into a moderate to high risk. In fact, if you look at, I hope we'll be discussing quite a bit about the, we can discuss about there's a Lipid Association of India, as you know, and I think Dr. Jayant, who should be joining us soon, is actually part of that group, as far as I know, Jayant Yadav. So it's a big group that is doing it, cardiologists and endocrinologists and all that. So in that, it is clear that if you are an Asian or if you're an Indian, let's take it as Indian, if you're an Indian and if you have diabetes, you're already into the high risk group. All you need is one more risk factor, which almost all of them will have, a hypertension or dyslipidemia or a family history. So one of these they will have. So I think when you look at Indians, the group really shrinks. There's very few people we should be looking at avoiding statins. I know the reality is different. We will discuss that in future, in this thing. But pregnancy certainly, and as he has said, less than a adolescent and those group, certainly, because women in that age group, clearly statins we can't give in that age group. But most of Indians with risk should really be on a statin. And there he is. Yeah, so I'm sure he will add to that. We would like to hear you as well before we move on. So the question really from Gauri is, when should we be avoiding statins? Or should we?
Can I Just
I
before
had a debate that hall.
Jan starts, with permission of Gauri, I think
sir.
that was the important thing about liver and stratification of
Sir.
LFTs.
Sir.
Suppose if you more than 3 times, then probably you will be worried. Second is I was talking about starting a statin and getting your liver derangements.
Sir.
I think these are some of the things that you have to keep in mind.
So
But of course,
having learned the contraindications or cautions that we need to start a statin, now we will move on to statin management in dyslipidemia is very simple. So people don't require, people who require modest statin, people who require high intensity statin. So we need to know what is this concept of this moderate intensity statin therapy and high intensity statin therapy. So if you see any of the guidelines, be it Canadian Journal, AACE, ESC or ADA, any of the guidelines, they look into these concepts. Sorry. So whether the patient require a moderate intensity statin or high intensity statin. Now, may I request Arun sir, like what is this concept of moderate intensity statin and high intensity statin?
Okay, I think this is really based on, I mean, it should be either moderate intensity or high intensity. So when you say moderate intensity, you're looking at the standard dose of atorvastatin of 40 and residual of 10. And with the high intensity, you go the double of that. So, 20 of atorvastatin and 40 being the higher dose. So, the important thing here is that you risk stratify the patients. If they are of high risk, then you really go for a high intensity statin from very high intense and extreme risk. We'll come to that later. But those with a moderate to high risk would be, to start with, you can go for a moderate intensity statin. So it really depends on the risk stratification that you. But starting with that, the important thing is that you start statin, because that itself gives you a significant, I'm sure Gauri wants to explain that in this slide, isn't it?
Sir.
But even starting a statin, you're getting significant improvement. On top of that, many a times when you intensify the dose, or when you increase the dose, when you double the dose, you may not get that sort of increase on top of it, which is why sometimes it is very difficult to treat to target. Treating dyslipidemia to targets are extremely difficult sometimes with statin in a lot of our patients, largely because the first response to statin is very good with the moderate intensity. When you go to the high intensity, you may not get such an exponential improvement in the LDL.
So very nicely said. So the first dose of statin is going to be the most important, because as you see in this chart, rosuvastatin, when we start with the 10 mg, the reduction is going to be 46%. When you move from 10 mg to 20 mg, it is not 46 plus 46, 92. The beneficial effect is going to be only another 6% reduction. From 20 to 40, as you move, the reduction is going to be another just 3%. So as you start with low dose and accumulate over a period of time. As you accumulate or as you give the high intensity statin, it doesn't mean that it addresses the full. From 46, it moves on to probably 53 or 54% reduction in the LDL. So this is something which we need to bear in mind when our patient requires. So having established this fact, we'll just look into this case. Surya, male, 46 years. His diabetes for the past 12 years. He's hypertensive. His blood pressure is well under control, on medication. Diabetes runs in his family. So with this background, what is the risk of the individual? Does he need a high intensity statin or a moderate intensity statin? So how do we need to put this patient? We know like this patient needs a statin, with all the panelists explained. So how are we going to risk stratify him, whether he needs a moderate intensity or a high intensity statin? So do we do with some relevant history? So, Panda, sir.
We know that being diabetes, somebody is 4 times in the higher atherosclerotic cardiovascular risk than non-diabetic. So patient is diabetic itself is a high cardiovascular risk, and he is hypertensive as well. But other history of coronary artery disease or PTCA or any procedures is not there. Here I'll prefer to go with moderate intensity statin and then try to escalate if at all it will be required.
Sir. So the patient doesn't have any history of premature cardiac death in the family, but he is hypertensive on medication, no CAT, no microvascular changes, no smokers. With the available information, sir has said like he needs moderate intensity statin. Or do we need to really look into some risk score? So to call him whether he will need a moderate intensity or initially to start with high intensity statin. So are we looking at some of the risk scores? Will it help in telling like whether he will need a moderate intensity or straight away I can put him on high intensity statins? So Dr. Tirthankar, sir.
Can I just come in? I think that here is a place about moderate and high intensity where your clinical wisdom comes with the pedantics. I mean our theoretical support we have. Now remember that if you want to dissect the evidence for lipid treatment, then I again classify them as how strong is the evidence. I believe that there should be no controversy in 1A evidence. What I mean is that the class 1 evidence and level A evidence. So that is what is most important. Putting it in a very simplified manner, primary prevention, you are aiming for mild to moderate, less than 100 LDLC. But if it has got a high risk or risk, you want to get it below 70, level 1A evidence. If you come to even secondary, what I'm talking is after an ASCVD or thing, less than 70, 1A evidence with a high statin. Now the question is, then do you want 55 after that? Remember, even then the PCSK9 inhibitor evidence is 2A and level B. So then somebody talks of 40. If it is another myocardial infarction in 2 years, yes, we would go for PCSK9 probably. So I think that even if you look at asteroid trial, then if you compare the moderate versus high dose, then you know the difference in total cholesterol, 2%. So you go from 40 to 80 in atorvastatin, or you go in rosuvastatin from 20 to 40. The difference in TC is 2%. So 100 coming to 62 and 60. Now, I believe that lipid treatment is as individual as glycemic control. You really sit with the patient, look at the parameter of that individual, what you are thinking, and what is the indicated. In this, I agree with Arun and both of them.
Sir, when we look at the parameters, do we look into any
now
of these
you go for
risk
score.
scores, sir?
Now, once you are confused up to here, because there is so much of literature in the market, but there is no doubt about 1A evidence. We start a moderate. Now then you go for the scoring. I am slightly in bias about Q-RIS3 because they take ethnicity, alcohol, steroids, and rheumatoid arthritis on board. Of course, ASCVD and FRS, Framingham risk score, are very good. They are comparing high risk, 10 and 20%. But you can do risk scoring. There's a very simple in British that we used to have on the back page. So where you can have the pharmacopoeia risk scoring that you don't have to remember anything, just put the age, diabetic, non-diabetic. There's more than 10% you are worried about. So I would say that it would probably go 8 to 10% risk score in this patient, and therefore moderate statin would be good enough. But I still insist as a take-home message that without complicating matter, 1A evidence should not be violated. 2A, 2B can be discussed. Thank you.
So my question here, sir, there are various scores. Like we have Q-RISK score, we have Framingham risk score, we have an independent atherosclerotic vascular disease risk score. There are ESC tells another risk score where there are some ethnic population also included. So with so much of scores, which score, if at all, if I want to use one risk score, which score should I look at for this patient?
I would say that there are few scoring systems which are well vindicated. They are well established. FRS, ASCVD, Q-RIS3. So I would like you to be comfortable and use one that you are comfortable with. They are all vindicated and well established. So in Britain, you would see Q-RIS3 being used very rapidly. In US, probably FRS and D. So feel comfortable. All of them are coming from a very hard evidence. And then I do not have a bias against any of them. Feel comfortable, but use a vindicated, well-established scoring. Thank you.
You know that Lipid Association of India has a score, LAI.
Sir.
Lipid Association of India has come with a score pertaining to the Indian patients. It's quite reasonable, like RSSDI guideline. It's quite reasonable and holds good for our ethnic patients.
Sir.
That can also be taken into consideration.
It's available online,
Yeah,
sir?
it's all available online.
Okay. So we have various scores, and as sir said, like we can be comfortable. Most of the scores are plus and minus, they are going to drive the same thing. For primary prevention, we look at FRS, otherwise ACVD or Q risk score, as has been discussed, we can look into. So now my question goes to Dr. Arun sir. So we haven't done a lipid profile yet. So, but we are starting already we have started the patient on moderate intensity statin. So what should I rely upon? There are some problems with the lipid profile per se, or should I look at non-HDL, or there are fancy testings now, APO little a and APO B. So what are all these things, various things which all the guidelines talk about these things. So what is the utility of it, and where should the clinician be headed in doing the investigation?
Okay, I think you want to put me on a spot, isn't it? That's why you have come with this question.
So per se, the LDL, when we
Yes.
do, it may like for this patient, say for example, we do a calculated LDL. And we see like for this patient, it gives a LDL of 40. It looks more than normal for us, like when we do this. So does it mean I can just, since the target LDL is achieved, can I just leave this patient without even a statin? Or what should I
So
look at?
do you want to go back to the previous
Yes,
slide? I think that makes it easy. So, yeah. So the thing really is, if you had all the resources, so once you have, you're talking about the LDL and you have controlled the LDL, and you're saying, okay, this is not you have quantified the risk, you have started a moderate intensity statin.
No, even before starting, sir.
Or even before starting. I mean,
Yes,
I suppose as we have discussed, if the risk scores are showing that somebody with diabetes and risk factors, the risk score is clear, and we have looked at that, and if that is there, then there is no question. There
Sir,
is no
for
need
this
to
patient,
immediate.
the risk
Yeah.
score says that he should be high intensity
Oh, okay,
statin.
you're saying
But
that
his
LDL
LDL
is-
is
okay.
only 40. So should I put this patient on statin or not by the
Yeah,
lipid profile?
I'll tell you why. So basically, LDL alone would not be the criteria we would need to use in this. So ideally, as Dr. Yadav was saying, we should look at lipoprotein A and ApoB. However, these are costly tests. So are we going to jump and do these things in all our patients? We are not. So a useful and a very easy calculation would be a non-HDL, which, as you know, is pretty easy. So total cholesterol minus HDL, and you get the non-HDL. And that actually is a rough calculation of the lipoprotein A and the apoprotein B. And so what we call as the residual risk, or, that is what is being calculated. So in fact, if you look at even this Lipid Association of India guidelines that's going to come out, I was just saying earlier before you came that you are part of that. And, although we were missing you there, we did tell that.
Sir.
Yes. Yeah.
I wish that at times you make that topic as a discussion point, and we'll give you some important data of patients of Indian ethnicity.
Yeah, we would like to hear from you in that conclusion as to what you would suggest from that. But so what they say is that you always look at LDL first. So just to simplify things, you look at LDL first. If LDL is not meeting the criteria, you still have to look at the non-HDL, because that has to be used as a co-risk factor or whatever. So you look at that, that is easier. And then comes other things. So if in an affordable patient or a patient whom you feel, as we were saying, sometimes you have to use your clinical listing also. You feel that this patient is at higher risk. There is certainly a point for calculating the LPA or the apoprotein B. But something that we can do in clinic very easily is looking at the non-HDL, and if that meets the levels, which is, as you know, it is 30 more than the LDL. So you look at that and then decide whether to treat. So that would be how I would go in this patient.
So when should I ask for ApoB, sir? In that case, should I ask for an ApoB, or especially the Canadian guideline says once in lifetime, at the time of diagnosis, when you do the first lipid profile, all the patients should be done a LPA, because it is genetically linked and it doesn't vary with patient to patient, because LDL, if you see, at some point of life, his LDL might be 130. Do it 5 years later, measured LDL, it might be 160, it might be 180. And these sort of problems are there with LDL, even if you do a direct LDL measurement. So are we justified in asking an LPA, small, little a, for the patients on diagnosis or at 40 years?
I mean, I would say yes, if you think there is a risk, it is definitely justified in asking. And as you rightly said, at least one time. The reason why we don't necessarily go with doing this in everybody is because the evidence of manipulating that or treating that and getting the desired result is still not great. And the medications we have, obviously, many a times we go by what we have in hand in terms of effective treatment modalities. And what we have is a statin and a stemib and, of course, the icosapentaenoic acid or what we have now. So those are the ones that we have. Again, I'm sure we'll discuss that later.
Yeah,
but
actually,
yeah.
That's a research panel. You keep ApoB and the lipoprotein small a in the research panel, and because if you'll get it to a routine advice, not only once in lifetime, every visit you'll see these tests are advised, you know the reason. And then LDL is a very good marker, and atherogenic dyslipidemia in Indian patients are well evident by a routine lipid profile. So once in lifetime, okay, we can know many things from that. In good centers they can practice, but in clinical guideline, they don't come.
So
Absolutely.
for all practical purposes, LDL holds good for the patient. So diabetes.
Gauri,
the-
can I
Sir,
just come
yes,
in?
sir.
I think to keep it simple, it is very important. This is a very important message you are giving. I believe that in primary prevention, simple cases, I should be happy with an LDL-C. If I have to do ApoB and non-HDL cholesterol, which are very good, but I would reserve them for either secondary or very high risk patients of diabetes. And when I'm thinking that there is anything more I can do to this individual patient. But to keep things simple, I think we should go for a lipid. Nowadays, LPs are even available in our routine cardiac screening and things. But I think we should be slightly more discreet in using them. Yeah, it's slightly discreet.
Sir. So that answers most of our queries. Like this patient needs statin. Diabetes statin indicated conditions are age above 40 years that the panelists have told. Age above 30 years, and if the duration of diabetes is more than 15, then we are justified. Microvascular changes, and we know what statin dose that we need to use. So now the question comes. So the most important question, which statin? Is it atorvastatin or rosuvastatin or any other statin? So I would take Jain Panda sir to take the question.
You have already told about the indications of
Sir.
primary prevention and the 40 years and 30 years of duration of diabetes, the microvascular changes. When it comes to question of a statin, you see, their efficacy is dependent on the doses. If we are starting with the atorvastatin, there are few people who are convinced with the atorvastatin and few are with rosuva. I personally don't see much difference between these two molecules. There are other molecules like simvastatin, there are other molecules like pitavastatin, and then they had some issues or other, but they are not much in the practice. We practice either atorva or rosuva, and simply remember the 10 milligram atorvastatin is equivalent to 5 milligram of rosuvastatin. And then it all depends, the different school of thought put different evidences, but efficacy wise, clinically, we can use either, but twice the dose of atorvastatin will equalize the half the dose of rosuvastatin.
I think Stellar study tells you that rosu is more effective in reduction of LDL-C in comparison. But I think I agree with him that you can start any. I'm more interested in the targets rather than one of the two you were using. As long as the targets are fine, I'm happy.
Yeah, I think it's mainly going by evidences. And if you look at the large number of studies, all the initial studies were on simvastatin, but they are less powerful. And all the recent studies, recent or in the last maybe couple of decades, is on atorvastatin, rosuvastatin. As both my respected colleagues have said, both are extremely effective, molecules. One is double the dose of the other one. So then that equivalence comes in. So the evidence is there, so we can confidently use one of those. Others, Simva, certainly the evidence is there, but then obviously its effectiveness is much less. So that is why we go for this. So I think that, stick to one of those, whichever is fine.
So between atorvastatin and rosuvastatin, it is choice. It is personal choice. So now having said that,
It all depends which company you want to support, who is regular in your clinic, but balance the dose.
okay. So how low to go in this patient? So what is the target that we are looking for in this patient? Are we some of these evidences that we have derived? They say like in newborn we have an LDL of about 40. So that is the dose that we need to go. So how low to? Some of these trials have showed. Now we have objectively also. We have most of these trials are showing that you can go as low as possible, less than 55, 40. It is all possible. So what should be the target in this given patient? We are not using any fancy drugs.
Yeah,
With statins alone, how low to go?
I was about to tell about this 4S trial, which came almost 15-20 years back with simvastatin. And if you summarize all the trials of the world regarding how low to go, 3 things I'll tell to remember. Lower is better, earlier is better, and lifelong is better. It simply shorts out many more questions. Usually you titrate the dose to bring it in the range. And range is around 150 for triglyceride and the cholesterol, and around 70 for the LDL. And HDL, we don't know which drug increases, which drug doesn't. But LDL, cholesterol, and triglyceride, if target is made, we are happy. So it's important that you bring it down earlier. It's not that years after the problem or the diabetes or the hypertension you focus on this. So 3 things in most of the trials they have concluded: lower is better, earlier is better, and second thing is lifelong is better. Because once it's stopped, again the lipids go high and the risk comes. And at that time you can go to combination therapy, which we will discuss, but this is my opinion.
Do you look into any numbers over there, sir? So I'm happy with 55, I'm happy with 70. So what would be the magic number that we are looking at in this patient, sir?
Yeah, for LDL you're telling?
Yes, LDL, sir.
70?
70. Yeah. Okay, sir. So now our patient, his ACVD risk as per the calculator that we showed is about 9%, which makes him to be put on high intensity statin. He's on rosuvastatin 40 mg. So his lipid profiles are like this. His LDL is now 120 milligram per deciliter. And as we see, like there is a residual risk always. So we need to address this residual risk. So his LDL is now 120 milligram per deciliter. Of this, there are some fancy drugs, and we have a cardiologist over here. So how do we address? So should we further escalate with bembinoic acid or PCSK9, or we are happy with the age-old STMB how we are treating? So what should be our choice now?
The LDL 120 is not acceptable. Of course, we need to escalate. And escalating, as already discussed, going to high intensity statin or escalating by dose. I'll prefer.
We have given the maximum statin, sir.
Yeah.
Now our LDL is 120.
Now addition of the drugs is advocated, and ezetimibe is a very reliable drug which you can aid. And of course, the latest launch is bempedoic acid. I don't know how many in India can accept the PCSK9 and its cost and its delivery, but I'll prefer to go for a combination therapy than trying the other way around.
Target.
To achieve target, after the statin, we'll go for ezetimibe, and still we are not doing it, we'll go for PCSK9.
I think we should look at the target very carefully, that we need to achieve there. And for that matter, you can use ezetimibe. That is the first thing to go by. And then, of course, I agree, PCSK9 is fortunately or unfortunately not as cheap as an ezetimibe. So we have to take that on board. And I think that usually this is a rarity that the high dose of rosu, you still run at 120. So I think that is not very frequently that we see. So, yeah, hypothetical situation. So let us hope that we are below 100.
Okay,
and
sir.
in patients below 70 with the high dose. But ezetimibe is the one to go. PCSK9 in a very high risk and secondary. And of course, bempedoic acid if it's available and done. So that's my opinion. The target is more important, and 1A evidence is more important. Not as much as you expect with the statin, but yes, there are studies that have come up, and I think they also, as an add-on to statin, the evidence is, if I'm right, and they have done a
Outcome
placebo also.
cardiovascular data
Yeah.
are not available. There are
Yeah.
two clear studies which has come. Both the studies have showed, one looked at the LDL reduction and hardcore CB outcome data.
We don't have much experience with this molecule, but we have studies, couple of studies as told. But if we are unable to reach the target, either you can aid this, and the patients of statin intolerance, which you are discussing, with myositis, with hepatopathy, then we can switch over to bempedoic acid. And molecules are 180 milligram is well available.
Sir.
They have been compared with both placebo and as an add-on. But I think if the target is not achieved, we should go for it.
So the panel agrees with an add-on therapy of estimab in our patient. So having done that, but the triglycerides is 220. For discussion, I put 220, but some of them feel like even 220 is okay for our patient. Let us presume, like I have not corrected it. Let us presume the triglyceride with maximum dose of statin with add-on estimab. Still his triglycerides is about 350 milligram per deciliter. So 350. Now, are we going to give fibrate? So the data is not there, or the Indian drug saroglitazar, or there are some newer drugs which are available in India now. EPA has come in, like though it is very expensive, it costs about 100 rupees per day. The omega-3, synthetic omega-3 fatty acids have come, which has got good data than saroglitazar. So what is the take on this?
After the statin and the combination therapy with the ezetimibe and the PCSK9 and the bempedoic acid, if still, because they have little action on triglycerides, but still triglyceride is high, more than 200, I'll definitely treat hypertriglyceridemia, because more than 200 is a cardiovascular risk as well. So the first drug I'll prefer is fibrates, and Indian research, seraglutazar, also effective, that can be kept as an option, but both should not be combined. That's my opinion. But if it's more than 200, it need to be combined with the drugs used for the statin.
I think this is a minefield, what you have said, 220, and whether to treat or not.
Sir, we will keep it as 350, sir. 350, sir.
Now,
No,
let
sir.
me tell you 220 also.
No, we will
Now,
keep it
where
at 350,
does-
sir.
Where does the triglyceride come in picture? The triglyceride come in picture from the epidemiological studies. It comes from the epidemiological studies, therapeutic studies, and genetic studies. So all these tells you, I'm talking of TGRLs. So all these studies give you. And if you look at the trials, then you have got the ideal TNT, then of course reduce it, accord lipid, and then of course strength study, which says again icosapent not so good. So you have got all these studies to come. Now we know after the reduce it study and other studies that at least this icosapent is good in reducing triglyceride. We know fibrates are good in reducing triglyceride, and its correlation with ischemic heart disease is still, we have now more or less generally agreed. So trying to treat triglyceride should be correlated with the patient we are treating with. If we have got a high risk, but your score is a high risk patient, if it is a secondary patient, and if we find that you're even above 200, as he's saying, that we should at least try to add something. That may be icosapent. Because we know that triglyceride, but then what the problem is, that direct correlation between ischemic heart disease and triglyceride is very difficult to establish. Once you establish in the meta-analysis, then if you do the multivariate analysis, then that correlation goes away. Then secondly, the triglyceride itself is a variable parameter from time to time in the patient. So considering all this, you have to very much individualize when you are trying to target triglycerides. Above 500, I don't mind. That, of course, even for pancreatitis. Yeah. And in established ASD high risk score, you should individualize the patient and now go for the ACE 2021 guidelines on the triglyceride management. With all these studies on board, I think we should in high risk patient think about it.
If you remember, maybe 20 years before, 500 we are worried about triglyceride, maybe for the pancreatitis. But of late, the study is correlated with the cardiovascular outcome. Regarding EPA DHA, eicosapentaenoic and docosahexaenoic acid combinations. There are many preparations in the market, but you should not be happy with that. The dose prescribed is very high, as you told.
2 grams.
Yeah, yeah.
2 gram 2 times.
Yeah. So there are very few preparations with that dose, and they are costlier. If patient is able to afford that, we can go for that, or else we can be happy with the fibrate or seroclitazar, but don't combine both. I come across prescriptions combining fibrates and seroclitazar because those are the only 2 drugs, PPAR, alpha and gamma agonist and fibrates. That is not recommended.
Arun sir, you want to add?
Yeah, I think, lack of time, I'll keep it short. I would prefer fibrates. Okay, the cardiovascular benefits may not be very clear at this point, but still, if you want to reduce the triglyceride, the area between 200 and 500 is still vague, as my experts have, as my colleagues have said. But if we are going for it, then we should go for fibrates in our scenario. Certainly, the other drugs are very promising, and we'll hopefully hear more about it in future.
So the messages are clear. Now we will go on to shortly, Mr. Alex. So 2 minutes case, 78 years old, diabetic 15 years, HbA1c 7.8, hypertensive, microvascular changes, his EGFR is 54. His total cholesterol is 220, HDL is 30, triglyceride is 220, LDL is 140. Considering his age, so I will just pass on the question to Tirthankar sir. So will you start statin, or if he is already on statin, considering his age, will we be down titrating statin over here? So the question is simple. We have 2 questions. Will we start statin, or how do we go about it?
Of course, we will be starting statin, and then maybe
At 78 years,
yeah,
sir.
78 years, but we don't know about the statin intolerance or there are some decrease in the EGFR, but the hepatic parameters, I suppose, normal.
Normal, sir.
Normal, and then though he's elderly, till he developed intolerance, I'll prefer statin as the first choice, and maybe in most of the time we'll be happy with the statins controlling the targets. If not, we'll think of combining other drugs.
So as this study shows, like it is irrespective of whether someone is less than 55 or 75, the vascular changes are same. So it is okay to start even at the age of 75, as sir has said. So if somebody is on 40 mg statin, will you down titrate, sir? I will, Tirthankar sir, will you down titrate from 40 mg to?
In view of the age, I'll prefer to go for a moderate dose than a high intensity statin in this patient. And then if required, we can opt titrate. But starting with a high intensity dose may not be tolerated at this age.
If you look at the Zodiac 13 study, they divided the patient between 60 to 75 and above 75. Above 75, starting a statin gave no correlation with the cardiovascular outcome. So that is one thing. Second is, if you take the diabetes duration less than 8 years, the fact remains same. But if you have long duration of diabetes and you have got not targets LDL, then it is visible definitely to continue, and you need to treat them. If there is a secondary or acute event or something, very high risk or ASCVD, there is a place for moderate dose statin. So elderly, you are more ambivalent in trying to see and use individualize the patient.
So with this carry home points, I'd like to take Abraham Oman sir is here. So do you want to comment anything on this, sir?
I was listening to the talk or the part where the LDL target was not achieved. So basically, that particular case where the patient was on 40 rosuvastatin and LDL is still 120. The easy thing to remember is that higher 40 milligrams of rosuvastatin or 80 atorvastatin roughly reduces the LDL by between 50 to 60%. But if you add estimib, it becomes about 65 to 75%. And if you add bempedoic acid to that, then becomes about 85%. So PCSK9 again reduces by about 85%. So one thing which I do is that I add histamine first, then add bempedoic acid, and almost everybody, and one part of the trial where with PCSK9 I'm not getting patients because almost everybody is controlled. Second is elderly. That is the tricky thing, because these data comes from West, where in that particular many of the things, diabetic populations are less and diabetics are much more healthier. And there is a Saber study from UK which compared whites, Caucasians versus blacks versus South Asians. And South Asians have much more atherosclerotic vascular disease. And as per ESC guidelines also, somebody having diabetes for more than 10 years, they come under moderately high risk. So I would look at the biological age as well as the chronological age. If he's totally very homebound, bedbound, I would not increase. But if that person thinks that, or we assess that he's got a good life expectancy, maybe another 10 years more. And Tamil Nadu, the life expectancy is, I think, touching 80. In Kerala, it is 85. So such people, I think we should give the benefit of more aggressive treatment.
Thank you, sir. Thanks a lot for your input, sir. With this, I would like to thank all the panelists for joining us here. Thank you all for attending this session. May I hand over the session to Sai Kondala, sir, to take further, please. Thank you, sir.